How to improve childhood obesity. In the United States, the number of children with obesity has continued to rise over the past 2 decades. Obesity in childhood poses immediate and future health risks. Parents, guardians, and teachers can help children maintain a healthy weight by helping them develop healthy eating habits and limiting calorie-rich temptations. You also want to help children be physically active, have reduced screen time, and get adequate sleep. The goal for children who are overweight is to reduce the rate of weight gain while allowing normal growth and development. Children should not be placed on a weight reduction diet without the consultation of a healthcare provider. Prevention of childhood obesity. Prevention is key to success for obesity control, as many but not all obese children will eventually become obese adults. Tracking, or the likelihood of persistence of childhood obesity into adult, is related to age. The management of obesity in adults is a difficult and often unsuccessful feat, especially in the absence of a known organic etiopathogenesis like leptin deficiency and other hormonal abnormalities. Prevention of childhood obesity, on the other hand, can be more rewarding, providing better chances for reducing long-term complications. There are 3 levels of prevention in dealing with childhood obesity. Number 1. Primordial prevention. Deals with keeping a healthy weight and a normal BMI throughout childhood and into teens. Number 2. Primary prevention. Aims to prevent overweight children from becoming obese. Number 3. Secondary prevention. Directed toward the treatment of obesity so as to reduce the comorbidities and reverse overweight and obesity if possible. Inculcating healthy practices like plant-based foods and fruit consumption and inclusion of exercises and active lifestyle form the pillars of the prevention program. All of the previously mentioned strategies, when combined together, can be put into practice sequentially from perinatal to adolescence as follows. Perinatal. This includes adequate prenatal nutrition with optimal maternal weight gain, good blood sugar control in diabetics, postpartum weight loss with exercises, and nutritional counseling. Infancy. Early initiation of breastfeeding, exclusive breastfeeding for 6 months followed by inclusion of solid foods, providing a balanced diet with avoidance of unhealthy calorie-rich snacks, and close monitoring of weight gain. Preschool. Providing nutritional education to parents and children so as to develop healthy eating practices, offer healthy food preferences by giving early experience of different food and flavors, and following closely the rate of weight gain to prevent early adiposity rebound. Childhood. Monitoring both the weight and height, preventing excessive prepubertal adiposity, providing nutritional counseling, and emphasis on daily physical activity. Adolescence. Prevent the increase in weight after growth spurt, maintain healthy eating behavior, and reinforcing the need for daily exercise and workouts. Furthermore, advocate nutritional goals such as the traffic light diet. Green, which means go, includes food which is low in calories and can be eaten without any restrictions. Yellow, which means caution, are food items with moderate high-calorie content and can be eaten only in moderation. Red, which means stop, are high-calorie food items which should be avoided or eaten rarely. Physical activity and behavior therapy. Physical activity is the key component for prevention and management of obesity. Preschool children require unstructured activities and thus will benefit from outdoor play and games. On the other hand, school-going children and adolescents require at least 60 minutes of daily physical activity, out of which 30 minutes should be structured activities like sports and supervised exercises. This has also been recommended by American Academy of Pediatrics. Simply providing education on obesity-related health risks, nutrition, and physical activity is insufficient to induce behavioral change. The best established counseling techniques used for pediatric obesity treatment use a behavioral change model which includes the following elements. Self-monitoring of target behaviors like logs of food, activity, or other behaviors recorded by patient or family. This allows the child and family to recognize the behaviors contributing to their weight gain. Clinician feedback throughout the self-monitoring process is essential to monitor the behavior change. A patient's food log may also identify other contributors to eating behaviors such as mealtime environment, boredom, and level of hunger, all of which can be valuable in the evaluation of stimulus control. Stimulus control to reduce environmental cues that contribute to unhealthy behaviors. This includes reducing access to unhealthy behaviors, like removing some categories of food from the house or removing television from the bedroom, and also efforts to establish new, healthier daily routines, such as making fruits and vegetables more accessible. Goal setting for healthy behaviors rather than strict weight goals. Goal setting is widely used for inspiring behavioral change. However, the process can be detrimental if goals are not realistic and maintainable. Appropriate goals are specific, measurable, attainable, realistic, and timely, or SMART. Contracting for selected nutrition or activity goals. Contracting is the explicit agreement to give a reward for the achievement of a specific goal. This helps children focus on specific behaviors and provides structure and incentive to their goal-setting process. Positive reinforcement on target behaviors. Positive reinforcement can be in the form of praise for healthy behaviors or in the form of rewards for achieving specific goals. The rewards should be negotiated by the parent and the child, ideally facilitated by the provider to ensure that the rewards are appropriate. Rewards should be small activities or privileges that the child can participate in frequently, rather than monetary incentive or toys. Food should not be used as a reward. Despite some discrepancy in study outcomes of increasing physical activity as a means to lower BMI, increasing the physical activity level of the child and family is a key focus in obesity treatment. As with nutrition goals, strategies for increasing physical activity are individualized. Clinicians should take into account the developmental stage of the child, family schedule, and personal preferences for activity while being mindful of sedentary activity. Clinicians can support the change process by consistently advising children and families to be physically active, suggesting options, and encouraging goal setting. In addition, community participation can be encouraged by forming partnerships with local fitness centers and schools. To increase physical activity in children, it is often helpful to consider a variety of options. Structured physical activity like organized sports or performance arts may be team-based or individual, and competitive or non-competitive. Less structured activities include recreational sports with peers or family, self-directed physical training, and lifestyle activity. Although these categories overlap, they provide expanded and diverse options and increase the opportunities for physical activity for the child and family. For preschool-aged children, unstructured activity like outdoor play is simple and useful. Providers can boost the level of activity in this group by prescribing playground time and providing a list of local resources like playgrounds or other opportunities for active play, in addition to discouraging sedentary time like television use. The provider can also encourage parents to consider physical activity levels when they make choices regarding daycare and after-school programs. Substantial evidence supports the importance of reducing sedentary activity as a means of preventing and treating obesity in children. Reducing sedentary activity has the secondary benefit of reducing the calorie intake and thus may provide to be more effective than increasing structured physical activity. In developed countries, overindulgence in leisure activities and entertainment such as television, computer and internet, virtual gaming, and other media are the root cause of sedentary lifestyle. In fact, television viewing is the single best established environmental cause in the evolution of childhood obesity. Data on the role of other media in the development of obesity are lacking. It is recommended that television viewing and other screen time other than homework is restricted to less than 2 hours daily, and that children under the age of 2 years avoid television altogether. Because many children initially will view television substantially more than this target, the first step should be in decreasing their present amount. School-wide campaigns and messages and behavioral interventions using reinforcement and reward strategies have been effective in reducing television use. Behavioral treatment strategies detailed earlier, such as self-monitoring, can also be useful. Children and families should go monitor their present amount of media use and then set goals to reduce it. The following recommendations are made in keeping with the American Academy of Pediatrics policy statement. No television set in the child's bedroom. No television viewing during meals. Maximum time for television and media viewing of 2 hours or some strategy that approximates this limit. No media viewing for children under 2 years of age. Substituting healthier behaviors and entertainment is helpful for accomplishment of these goals. For younger children, this is through the use of active games such as tag, hula hooping, and obstacle courses. Quiet, non-media activities such as reading aloud or playing board games are also acceptable substitutes because they avoid television advertising and establish patterns of family interaction that may ultimately lead to active play. Taking activity breaks during television commercials both reduces exposure to advertising and establishes specific windows for activity. An average hour of television features 20 minutes of commercials, with half of them being food-related. Strategies to reduce media use for older children are more variable and are best addressed through a combination of self-monitoring, establishment of family media limits, and negotiation to identify substitute activities. Because both media and homework are often accessed through the computer, it can be difficult for a parent to monitor a child's actual media use. For these and other reasons, engagement of the child in the behavior change process is essential, using the behavioral strategies outlined earlier. Develop healthy eating habits. To help children develop healthy eating habits, provide plenty of vegetables, fruits, and whole grain products. Include low-fat or non-fat milk or dairy products, including cheese and yogurt. Choose lean meats, poultry, fish, lentils, and beans for protein. Encourage your family to drink lots of water. Limit sugary drinks. Limit consumption of sugar and saturated fat. Remember that small changes every day can lead to success. Limit calorie-rich temptations. Reducing the availability of high-fat and high-sugar or salty snacks can help your children develop healthy eating habits. Only allow your children to eat these foods rarely so that they truly will be treated. Here are examples of easy-to-prepare, low-fat and low-sugar snacks that are 100 calories or less. 1 cup carrots, broccoli, or bell peppers with 2 tablespoons of hummus. A medium apple or banana. 1 cup blueberries or grapes. 1/4 cup of tuna wrapped in a lettuce leaf. A few homemade oven-baked kale chips. Help children stay active. In addition to being fun for children, regular physical activity has many health benefits, including strengthening bones, decreasing blood pressure, reducing stress and anxiety, increasing self-esteem, helping with weight management. Children ages 3 to 5 years old should be active throughout the day. Children and adolescents ages 6 to 17 years should be physically active at least 60 minutes each day. Include aerobic activity, which is anything that makes their hearts beat faster. Also include bone-strengthening activities such as running or jumping and muscle-strengthening activities such as climbing or push-ups. Remember that children imitate adults. Start adding physical activity to your own routine and encourage your child to join you. Reduce sedentary time. Although quiet time for reading and homework is fine, limit the time children watch television, play games, or surf the web to no more than 2 hours per day. Additionally, the American Academy of Pediatrics does not recommend television viewing for children aged 2 years or younger. Instead, encourage children to find fun activities to do with family members or on their own that simply involve more activity. Ensure adequate sleep. Too little sleep is associated with obesity, partly because inadequate sleep makes us eat more and be physically less active. Children need more sleep than adults, and the amount varies by age. In the end, childhood obesity today constitutes one of the most serious health concerns, both in the developed and the developing world. Obesity in childhood is causative for many chronic diseases, including type 2 diabetes, cardiovascular diseases, hypertension, osteoporosis, and some carcinomas. It also has psychosocial consequences and may contribute to a delay in academic and social functioning, as well as poor self-esteem and depression. The interventions for preventing and controlling obesity are mainly aimed at limiting the intake of sugar and high-calorie snacks with higher consumption of vegetable and fruit-based diet. This includes eating a calcium-rich high-fiber diet with balanced micronutrients, daily healthy breakfast and home-cooked family meals, smaller portion size, and a curtailment in eating out. Last but not least, decreasing the duration of screen time, especially television, and increasing the level of physical activity are vital for preventing childhood obesity. Over the last 30 years, the prevalence of childhood obesity has increased exponentially. Multifaceted strategies involving the public and private health sectors, along with community participation, are required to gradually reverse this trend. Make sure to share your experience with us and don't forget to subscribe, share, and like.